Okay, so good morning, everybody. My name is Chris Carrigan. I'm the expert data advisor for Use My Data, and this is another one of our members' educational sessions. These are really meant to be up to an hour. This one will be about 50 minutes, just to go through a particular topic that people have asked me to cover, either with me speaking or somebody else speaking. It's meant to be informal, so feel free to shout, ask, put your hand up, or press the chat button at any point. And at the end of it, I've only got about 10 slides. We'll go through some points. I'll try and explain things, and then we can just have a discussion, Q&A, chats, whatever afterwards, for anything you find confusing, anything we think we've missed, and anything else as well. Where we record these, we don't show the discussions on the recording, but we do show me talking to the slides so other people can watch them as well. So this was something we've been asked about loads and loads of times by people who say, they come across statistical terminology all the time, and sometimes it's difficult to understand. So what we wanted to do was to put on a session where we covered a layman's guide to statistical terms, and yes, I am that layman. So what we want to do is to go through a few basic things at the minute. So first of all, talking the talk, walking the walk. So I can certainly talk the talk. I've seen stats terms for goodness knows how many years, but I'm not a statistician. I'm not a trained statistician, but there is somebody on the call this morning who is a trained statistician, because he and I worked together over many years. And if there are other complicated questions that come up, I may just defer to him and ask him if he can help me out. A guy called Sean. But this is meant to be a lay introduction, a basic introduction to statistical terms. There are only about 10 slides, so don't get worried about being overburdened with things, and with plenty of time at the end for Q&A and chat. What I've also tried to do, rather than just make it boring around statistical terms, is show some examples of where data has been used in a particular way, where you might have seen these particular terminology, to give some insight to the reality of how some of these stats are used. If you're watching the recording on this, rather than we live here, you won't see the discussion, you'll just see the slides. And equally, anybody who's watching the recording or anybody in the room here, if there are other topics you want to cover, just shout up or email me at that email address, and we'll add them to the list of topics for the education sessions. So here are some things I thought we'd cover. We'll start right from the basic stuff around counts. Then we'll go into things like rates, which you will have seen on lots of slides and presentations, and standardized rates, which you'll see in some of the more complex stuff. Anybody who's involved in the research publications will have seen lots of things around standardized rates. Some conversation about where populations come from and why those are so important to producing reliable statistics, and then covering some of the more tricky stuff, confidence intervals, statistical significance, quartiles and quintiles, words that you might have come across in or seen at the bottom of things like the old COVID briefings. They had words such as these on there as well. There will be other things you come across in your daily lives, and when we get to the end of my list, we'll have plenty of time for you to shout and say, what does such and such a thing mean? But I'll get through these first. So let's start with the basic stuff around counts. It's pretty obvious, and there's an example of count on the top right of the screen, but basically a count of how many things are happening in a particular period of time. So the one on the top right is how many cancer diagnoses in a particular year. In fact, this is taken over 3 years and an average of those 3 years, but it's just a simple numerical count of what's going on. Just 1 second. I've just enabled the live transcription as well. Apologies for that. I should have done that earlier. So that's just a count. They're useful to a degree. You can look at volume. They're more useful in organizations which are affected directly by volume. So look at A&E, for instance. If you look at A&E attendance that's trust per month, that's massively important for individual hospitals, so they can actually manage their work on a day-to-day basis. They're less interested in rates and statistics and the more complicated statistics. They're really interested in numbers, activity, and that's true of quite a few people as well. They're useful to monitor throughput, activity, demand changes, but in terms of comparisons, it's not particularly helpful when you're just looking at numbers to do comparisons. For instance, if you've got a big A&E department and a small A&E department, it's not that useful to look at just basic numbers coming through, comparing one versus the other. They are useful, though, even in their raw setting of numbers. This is something that Cancer Research UK did with the National Cancer Intelligence Network data many years ago. And it's basically just the numbers, but presented in a slightly different way. So if I can get my highlighter pen to work, if you look down, oops, in this part here, this is basically saying number of people diagnosed in a particular period of time. This was in a 2-year period, I think. And they've just got those counts and given a percentage of the counts by a particular route of referral, how people arrive at a diagnosis. This is just a count of what happens in the year, the volume. But they've used the data in a different way because they've broken down into percentages, so it makes it more meaningful. And equally, if you look across there, pardon my yellow stripes, if you look about the number of people who are diagnosed through the national screening program, it breaks those counts down further by looking at how many of those people arrived at the early stage versus late stage. Early stage better for long-term prognosis, late stage less good. And they've done that for each one of the counts for the different referral routes in. So this is just a very basic use of numbers, but it's actually visually quite impactful the way they did it. And it's really useful in terms of understanding how people are arriving at a diagnosis and how effective those routes are at finding cancers earlier or not. I should credit the guy called Sean McPhail, who's actually on the call here, who was involved in developing this innovative methodology, which is still pretty groundbreaking in my mind. Let me just cancel my thing. If we move on from counts, you'll have heard the term of rates, and call them crude rates at the minute. So it's just a basic X over Y, a fraction. It's the recurrence of events over a particular period of time, or defines a people or a geography, so it's something over something, a count of something happening versus an underlying count of how many people it happened within, if you like. They're useful for various comparisons, and in their basic rate, you can see that, for instance, the incidence rate of lung cancer is higher than ovarian cancer. You know how many people are getting cancer, you know how many people get lung cancer, you know how many people get ovarian cancer. A over B for those two things lets you see that the rates higher lung cancer than ovarian cancer. It also lets you see some of the basic crude stuff, which is the incidence rate of lung cancer, for instance, is higher in Manchester than Surrey, but the incidence rate of breast cancer is higher in Surrey than Manchester. So even in their basic form, they can be quite useful, but they're still crude, but they're useful for a basic count, a basic indicator, but they don't account for things like population size, population profile, age profile, and a whole bunch of other things, which is why they're called crude. But you'll see these used quite a lot in lots of different statistical publications. If you then move on to standardized rates, so this builds in factors about the underlying population. So for instance, if you've got a population which is much older than average in a particular part of the country and a population which is much younger than average somewhere else, you'd expect the disease profile for a whole bunch of things to be very different in those two populations. So by standardizing, using standardized rates, it tries to cater for those things. And it lets you do a much more sensible comparison of one area of the country versus another area of the country. For instance, this is something that ONS produced, and this is again looking at all cancers diagnosed, but this has got the age standardized incidence rate per 100,000 people. So this is a more accurate reflection of reality. And again, it shows that the age standardized rate in the Northeast is much higher than it is in London. And this is where you get things like lifestyle factors and environmental factors, things like deprivation feeding it to as well, which are other ways you can look at some of these statistics and break them down even further. But this is where you'll get the ability to do a much more reliable comparison of, in this case, regions of England. The same methods are applied across all parts of the UK, by the way. It's just that I had an England slide available to me. And these are used extensively across the NHS, across public health, because they're a reliable indicator of where there are real true differences across the country. The other thing that people will see a lot of is this thing called confidence intervals. And if you're a lazy pseudo statistician like me, you never put confidence intervals on. But if you're a proper statistician, you always do, because they provide a measure of the reliability of a particular figure. So given the fact we know there are issues around data quality and completeness, we've all seen that within our own health records. We've heard about it in various other talks we've done on these education sessions. The figures you do are based on estimates, and you've got to figure out how you provide a measure how good those estimates are. And that's what confidence intervals do. So you'll see on lots of charts and presentations, it's presented in different ways. But if you look at the level of confidence of 95%, means that if you repeated this result, you probably get the same answer 19 out of 20 times. So it's trying to reduce the potential for this being about chance. If you've got a coin, you flip it up in the air 3 times, you could get a whole range of different answers. But if you did it 100 times, you'd be more reliably likely to get a 50-50 split of heads and tails, for instance, when you flip the coin. So the more times you do these things, the better results you get. And confidence intervals give you an indication of how reliable that result is likely to be. I say 95%, I think, means about 19 out of 20 times. If repeated it, you get the same answer. So pretty confident. 95%, I think, you'll see in lots of publications. They use that fairly standard. It also means that you can use those confidence intervals to compare the results between 2 different populations, between 2 different results. So the 95% means you've got an area of certainty, if you like. And when you get 2 results for 2 different parts of the country, if those areas of certainty overlap, then you can't really draw any conclusion. It's easier if I show you on a chart. So that's just something I pulled off the web. I'd taken out all the various different factors around the bottom, but the dot is the A over B figure, the rate. The green line shows the upper and lower confidence intervals. And where those confidence intervals overlap, you can't really tell much difference. So the red line is your baseline, what you're comparing to. And you'll see that all those different dots, there may be parts of the country, for instance, around performance. Where all those dots are, they've got confidence intervals. And if those are confidence intervals, the green line doesn't go beyond that red line of what you'd expect, then it's not statistically significant. But where you can see the red one, where it does drop below, that you would say is statistically significant. Now, what you'll see on lots of publications is those dots without the green lines. And we've seen this in lots of areas of the country where you work with lower populations, the numbers are less, so the confidence intervals become a bit wider because you get more just basic variation in the numbers. And if you were just to present the dots, and I was living in the locality which is just to the left of the red line, which is still below the red dotted, I'd say, this is terrible. We're below that red line. We need to do something about it. But in terms of reliability of those statistics, you've got to be really careful, because if it's not statistically significant, you can't really draw much conclusion from it. And that's one of the problems you get when you see statistics presented in the media in simplistic charts where they just show the dots without the confidence intervals. You can't really be sure that that result is statistically different than anywhere else. So that's something to certainly keep an eye on as you see more and more of these things appearing. Oops. The other point is about population. So we saw in the early ones around age standardization. How do you age standardize? Well, you age standardize because you know the fundamental profile of the population. So I mentioned Manchester and Surrey. They've got fundamentally different structures of population by age profile, by ethnicity, by a whole bunch of other things. And all those factors need to be taken into account when you're producing standardized rates. This is where the brainiacs of the world, the statisticians, do their job. That's why you can trust their statistics more than you can trust mine, frankly. But understanding the underlying population of the country is massively important. And that comes from basic things like the UK census, which we used to get once every 10 years, where you fill the form in. It also takes into account, beyond the census date, registrations of births and deaths. So there's the Office of National Statistics for instance, keep a track of what the current population looks like. And they produce tables of populations which statisticians use all the time to produce their standardization methods. So as population profiles shift in London, for instance, you have to cater for that when you're looking at standardizing statistics to make sure you can still compare like for like. You'll have heard that this concept of the aging population. one of my kids took offense to that when they were very young, because they thought I would talk about the Asian population all the time. Aging population, which is my Yorkshire accent. And it's basically reflecting that the age structure of the UK, the profile, is shifting more towards older age because of the low birth rates and people living longer. It's just a factor of good public health, I suppose, in one perspective. And if you were to look at that in visual form, this was produced around mid-2020. I think this is on the ONS website, Office for National Statistics website, and that shows a breakdown of what the population in this country looks like. Each one of the horizontal bars is an age. So if you go up the bars, that's the older age group. And as you move more towards the older age groups, you get less people because there's a natural decline as people die in later age. So somebody is what you'd expect. This is the population profile that is used to standardize all the statistics that get used, that get produced to compare like for like. There are different population profiles in England, Scotland, Ireland, and Wales. Different population profiles, certainly in different parts of the country. If you look at London as an extreme, the population of London, the profile looks quite different than it does in other parts of the country. There's a little spike as well there on the around about 73 of the number of people living with that age. I think that is back down to the end of the Second World War. We had a population spike, but I could be wrong if my maths is wrong. But this is a basic profile of the population in the country that's used by all statisticians to standardize the stats that they produce. There are other ways of looking at the population as well. So that first one, the red and blue, looked at age. This one is different. This looks at ethnicity. And this is just taking two aspects, white, British versus Indian. And you'll immediately see that the profile of different ethnic groups is different across the country, significantly different. So if you were to do the same profiling, ignoring ethnicity, then it ignores the fact that certain ethnic groups got a much different population profile. So the Indian population in the country has a bias towards much lower ages. And we know that diseases are less likely in the lower age group, and we're more likely to get poorly the older we get. And it would fundamentally shift the interpretation you could make if you'd ignored these sort of population profiles. This is why it's so important to keep an eye on all the different populations underneath and to begin to take those things into account. And this is why we have some really smart statisticians in this country who can do that. This might be the last one I was going to mention around quartiles and quintiles. So somebody asked me a few times, what does it mean by quintiles and quartiles and quintiles? It's basically a way of taking a whole set of the data and chunking it up into quarters, if you're doing quartiles, for instance. So you divide the population into quarters, and you can look at each of those quarters in its own right, rather than having to look at every individual case. So quartiles, the distribution is divided into 4, quintiles into 5, deciles, which you may have also seen, into 10. And what that means is if you've got a set of data, and there's a fairly standard bell curve for where data fits in a whole bunch of things. If you turn it on its side, it looks a bit like the population profile. And by taking a quarter of those in chunks, you'll see that the quarter profiles can be used to do particular types of analysis and group those things together. So you can look at the quintile 1, 2, 3, and 4 and group them together to give us sort of a picture, if you like, rather than having to do individual ages or age groups. So it's just another way of statistically using the data to try and chunk it up to make more sense of what can be quite complex information. An example would be the deprivation. So all the postcodes in the UK have got a deprivation figure against it. And if you live in that postcode area, you have a deprivation value assigned to you. And those are defined in quintiles. So rather than having billions and billions of deprivation figures, they simplistically divide them into, in this case, 5 groups. And each of us here has a deprivation value assigned with our postcode, either 1 to 5. And when you look at those and add up those numbers, you can analyze those by deprivation profile. And it lets you do some really useful things. It lets you look, in this case, around the effect of the late diagnosis of lung cancer, this case in Manchester, around the least deprived versus the most deprived in men or women. Men is blue, women is pink. Sorry, formulaic, I know, but this is from, I think, one of the local Manchester reports. And this is a way you can get a picture quite easily, quite quickly, but very impactful, just by taking data and chunking it into 5 groups, then analyzing those 5 groups. That's one of the ways that quintiles, quartiles, and deciles get used to try and make more sense of complex data. These things are really easy for people to understand. It's intuitive, and you find lots of the presentations of things like this in reports for political lobbying groups because they're quick to understand. So that was my 10 slides. That was my bunch of statistical terms. My first question was, it was really limited run through. There are lots and lots and lots of statistical terms that get used, and we'll hear about those if you've got any questions on some of those in a minute. Secondly, did that help? Other areas I think that we've missed, and I suppose one question that would come to the end of this is, should we be doing something about this? Do we need, or has anybody got access to a really useful patient-focused or person-focused document around statistical terms? So I'm going to go to Q&A in a minute. I'm going to stop the slides showing now. Just to say thank you for turning up and giving your time. Reminder that if there are topics that you want covered, we can put anything on. These are all requested by you. I don't make them up. So just please send them through to either me or to Emily or to Alison or whoever. Just let us know and we can put those on. Yeah, we'll put the recording on the members learning part of the website. We'll send a reminder out in the newsletter to say when that's available, and you can watch that again, and I'll put the slides on there as well.